Okay, so let's start off with our first case. And the way we're going to do this actually is by giving you a little bit of a clinical case with each of these examples. Why am I going to do that? Because the USMLE is going to do that. That's a pretty good reason. So I'm going to try to help prepare you, because almost all of your questions on your step 1 are going to be in the format of a clinical case. So you have to be ready to handle clinical cases and always be thinking about patients when you're studying. Alright, so let's say that a homeless gentleman who actually is an intravenous drug abuser, so he injects himself with heroin, and he doesn't always use the cleanest needles, unfortunately. So let's say that he actually develops fevers, night sweats, and when you listen to his heart, you hear a murmur, a systolic murmur. What do you think is going on? What do you think he has? Probably endocarditis, right? Right. I hope you're thinking that. Okay, so endocarditis. And so this is infection of the heart, and the heart valve specifically. What heart valve do you think is most likely affected? Let's think about this logically, okay? Then that's how you should always think, is just ask yourself why, right? Always try to find out the explanation, the reason for things, the mechanism for things, the pathophysiology. Those should be your buzzwords that you just search for. How do things work is how you should keep asking yourself over and over again. Okay? That's what I did, and it served me very well. And it's also very rewarding to actually know how things work. So you have all your blood draining into the right side of the heart. Okay? That's where all the blood from all your veins drains to. And then from the right side of the heart, from the right atrium, where does it drain into? So it's the right atrium, then it drains into the right ventricle. Okay, very good. So what is the first valve then that this infected blood will come into contact with? So actually the tricuspid valve. So that's what you have to remember. With intravenous drug abusers, you must remember that they are most often associated with infections of their tricuspid valve. Okay, very good. So let's say there's infection and vegetations that are building up on this tricuspid valve, and little bits and pieces chip off and flow away. So where does blood go from the right ventricle? Flows into the pulmonary artery to the lung, right? So these little infectious embolizations chip off and end up in the pulmonary arteries of the lung. So here's like a proximal artery. The way the arteries work is that they always are branching, and so in branching into smaller and smaller vessels. So that's why when a little piece of this vegetation here chipped off and got stuck in this pulmonary artery, it actually will block off blood flow to everything distal to it. And this infarction and this dead tissue now will have the appearance of a wedge, because that is the distribution of this blood vessel. Everything downstream from the secluded blood vessel will be cut off, and you will have infarction of tissue. What is the type of necrosis that is taking place in this dying tissue here? There's an event of coagulation and clotting leading to dying tissue. So coagulation leading to necrosis, coagulative necrosis. It's appropriately named. And what do you think this will look like under the microscope? So think hyaline, think pink. And we'll talk about why that is, but really it's due to a decrease in pH. We'll talk about the whole mechanism of this in a little bit, though. So the decrease in pH, though, denatures enzymes actually in the cells so that they can't even degrade themselves. So they just hang around like ghost-like remnants like we see here without nuclei. Kind of creepy, right? And eventually, like we start to see here, neutrophils start to trickle in about 24 hours later. Neutrophils enter and start to chew up all this dead tissue and take care of it. But before that, they're just pink, ghost-like remnants of the tissue that was. Alright, let's move on to the next example. Let's say that a child is exposed to other children. He plays with them in his daycare who have MRSA, methicillin-resistant Staphylococcus aureus. It's bad infections. So let's say that this kid develops an abscess in his skin that we see here. What type of necrosis do you think is taking place in his skin? The answer is liquefactive. What do you think we'll see microscopically here? Neutrophils. So just tons and tons of neutrophils. What do neutrophils do? you should remember from your path courses that they release what? Reactive oxygen species and other enzymes and things that will just degrade all tissue around them. Everything in sight. They'll take out everything. They're very non-specific killers. Even healthy tissue. So everything that they degrade and everything that's around them will be liquefied, hence the name liquefactive necrosis. Now there is one type of tissue that undergoes liquefactive necrosis even when there's a clot in the vasculature supplying that tissue. So there's a clot, and this tissue will undergo liquefactive necrosis. What is this tissue? What am I thinking of? It's the brain, and you have to know this for your USMLEs. You have to know this. It's so important. Okay? Remember that. And the reason really is somewhat unclear, but it's thought to be due to the brain's flimsy meshwork. So it just has a bunch of microglia and neurons, fatty neurons, and not really anything that can support the dead tissue. So once it dies, it just all collapses and liquefies into this soupy mush. So let's keep going here. Another example. Let's say that this lung belonged to a guy who developed fever, night sweats, cough, actually bloody cough, which is called, do you know the name for that? It's hemoptysis. And he just developed this over a course of a month and was losing weight and eventually died. So his lungs were cut open, and we see here that there's this cavitary or circular lesion in his upper lobe with surrounding cheesy-like material. What type of necrosis is this, and what is the organism causing this? So this is caseous necrosis, and the word caseous actually means cheesy. And the organism causing this is actually, most likely, do you know? Mycobacterium tuberculosis. And some other types of fungi like histoplasmosis and some other things too. So basically the cell wall of these bacteria is so fatty and cheesy that when macrophages try to degrade it, they can't really completely consume it and get rid of it. It just kind of hangs around and gets emulsified and leads to this cheesy-like debris that we see all over here. And the TB actually leads to destruction of the lung tissue in these cavitary circular lesions. So there's really a pathognomonic finding here when we take a look under the microscope. Do you know what we're going to see? So the answer is granulomas. And we'll talk more about these in a little bit, but basically these are just a collection of macrophages and even macrophages that come together and the nuclei all combine into one cell and form these multinucleated giant cells. So it's a bunch of macrophages and T cells, basically, are granulomas. We'll talk more in detail later on. Okay, so now let's talk about another example. Let's say that this individual has terrible epigastric pain that's radiating to his back, and he's an alcoholic. Alright, so what are you thinking here immediately, just based off the history? We're thinking pancreatitis, right? Yeah. And the reason that we're thinking that is because the pancreas, so here's kind of a rough sketch of the pancreas, the head and the tail, is actually only partially enveloped by the peritoneum. The tail of the pancreas, the very tip of the tail, actually is retroperitoneal, which means it's pressed up against the person's back. So if the pancreas is inflamed, then their back will hurt too. Alright, so why do we see pancreatitis in an individual that's an alcoholic? So alcohol actually activates the enzymes of the pancreas. So just if you think about it, the pancreas normally, what's its normal function? It normally releases lots of enzymes that degrade all the food that you eat. If these enzymes are activated within the actual pancreas, it'll start degrading the pancreas and lead to incredible inflammation, and all the fat and proteins in the pancreas will start getting degraded. So when the fat actually is degraded, like the peripancreatic fat that we see here, when it's degraded, fatty acids will be freed up. And fatty acids, are they positively charged or negatively charged? Negatively charged. And they will complex with a certain ion, that is calcium, that is positively charged. So this complexing of these two charged substances will lead to a process called, do you know? Actually, saponification. That just means forming a soap-like substance between the fatty acids and calcium. So, first of all, what type of necrosis is this called? Fatty necrosis. Okay, good. And what do you think this is going to look like under the microscope? Well, you'll see calcification, as expected, intermixed with fat lobules. Sounds appetizing, right? Okay. Next example. This is a fun one. So let's say that this is a heart valve from some poor kid who 2 weeks ago he actually had a sore throat, didn't get it treated, and then over the past couple days started developing fevers, night sweats, some nodules on his skin and rash on his skin, and even started dancing a funny little dance. And so all of these things are consistent with what diagnosis? It's a little tricky, but it's rheumatic fever, and this is so important to know for USMLE. So important, okay? And why did he have a sore throat? So he had a sore throat, an infection with what type of bacterium? Strep pyogenes. Group A, strep. Okay, so this bacterium actually, here's this little flagellum. So it actually has a little protein. Do you know what that name of that protein is? That's so pathologic. It's the M protein, okay? It's the M protein. Now, when this bacteria is in this kid's body, his body responds appropriately by synthesizing antibodies to the M protein. The only problem is that these antibodies also will bond to cells that look like the M protein in this kid's mitral valve. So the mitral valve resembles the M protein. That's terrible, because now these antibodies are going to attack his mitral valve. And then once that happens, you're going to listen to his heart and you're going to hear a murmur. What murmur do you think you'll expect if you listen?
If this is an acute rheumatic fever episode, then you would expect to hear a systolic murmur. Where is the mitral location best heard? So at the PMI, the point of maximal impulse, lower and laterally on this kid's chest. And where would it radiate to? How would you differentiate this from, say, aortic stenosis, which is also a systolic murmur? Well, this murmur would radiate somewhere. Where would it radiate to? Probably the axilla, so the armpit. And if it was aortic in origin, then it would radiate to the carotids. So that's how you can differentiate that.
So this is fibrinoid necrosis. This is the necrosis of immunologic disease. We see it in rheumatic fever. We also see it in lupus. Here's a blood vessel here. Systemic lupus erythematosus. That's actually an antigen and an antibody floating around in the blood vessels and causing all kinds of damage. So what's the problem with antibodies? Like what? So we have an antibody binding to your mitral valve. What's the big deal, okay? Why is that going to hurt anything? So here's why, and this is so important. You really need to remember this, and it's a nice immunology review too. So what inflammatory cascade do antibodies actually trigger? What do they set off? Actually, you have to remember this, the complement cascade, okay? And the reason it's named this is because it complements the immune system very nicely. So anytime there's an antibody and an antigen, that sets off the classical complement cascade. The alternative complement cascade is triggered by what? By bacterial products like endotoxin. Once complement is activated, there will be proteins split off, and one of them is C5a. What's so important about C5a? What is this chemotactic to? What will it call in? Neutrophils. And neutrophils, as we said before, they release the reactive oxygen species and just tear up everything in sight, including the blood vessel here and the heart valve here. What type of hypersensitivity? Well, that's a good immunology question. What type of hypersensitivity is rheumatic fever? So it's an antibody just binding to cells directly. That is cytotoxic, right? Cytotoxic to cells. That is type 2, cytotoxic. What about an antigen and an antibody floating around in serum? That is type 3. But you got to remember those types of hypersensitivity, okay? Type 1 is allergic response, like eosinophils and mast cells. Type 4 is, do you remember? Is delayed type, like poison ivy and contact dermatitis. All right. So again, reactive oxygen species, like we just said, they tear up things. Alright, the final type of necrosis that we'll talk about is what? This is a dead foot here in a diabetic. What type of necrosis is this? The tissue is rotting. This is gangrenous necrosis. Basically, gangrenous necrosis is a type of coagulative necrosis, but just with the addition of rotting flesh. So there's three main types that you need to know. The first one that we see here is dry gangrene, and this just means that neutrophils haven't arrived yet. If neutrophils have arrived, what type of gangrene is that? That's wet. Think of like the wet pus that are associated with neutrophils. Essentially, pus is dead neutrophils. Alright, and the final type, let's say there's just pockets of crepitus, like you press on this and you feel almost like there's some gas underneath the tissue. What type of gangrene is that? Well, that's appropriately named gas gangrene. And what types of bacteria can cause this very lethal type of gas gangrene? Clostridium perfringens, Closperf, and actually the one we just talked about, Strep pyogenes. Very bad type of gangrene. Gonna need amputation. Alright. And this is what it'll look like under the microscope. Basically just pockets of gas in the muscle tissue. Okay. So moving on here. So now that we talked about all the types of necrosis, we're now going to get into the main causes of necrosis. And what do you think is the number one cause of necrosis? That would be hypoxia, or generalized deprivation of oxygen to tissue. So when a tissue does not get oxygen, and there's three main types of hypoxia. So the first way we'll talk about, the first way tissue can be deprived of oxygen is the oxygen is just not getting into the bloodstream from the lungs. What would have to be the most common cause of this? Probably a ventilation perfusion mismatch. So either there's a problem like with intrapulmonary shunting in the patient's lungs, or there's a problem with perfusion of the lungs. Well, what do you think would be a common cause of a problem with perfusion? I would think of a pulmonary embolus, personally. By the way, how would you test for a PE? What would be the confirmatory test? CT angiogram. Okay, so that's one cause of hypoxia, just that the oxygen's not getting in the bloodstream from the lungs. But let's say, okay, oxygen made it into the bloodstream, and now we have an issue with clotting. So there's a decrease in flow of blood because there's an occlusion. This is the most common cause of hypoxia here. Why? How do I know that? Because what's the most common cause of death in the United States? Myocardial infarction, clotting of the coronary arteries. So ischemia is a big time cause of hypoxia and necrosis. You gotta know that. So, a decrease in blood flow equals ischemia for whatever cause. It could be a decrease in arterial blood flow or venous blood flow, whatever. And it doesn't always have to be due to a clot, as we'll see. The final type of hypoxia, let's say oxygen has made it into the bloodstream, but it can't be carried very well. So there's a problem with the carrying capacity of oxygen. And the most common cause of this is really just a decrease in these red blood cells, so anemia.